Hello, I'm John Hodgson from Cleveland. Okay, in the next couple of minutes, we're going to talk about several things here that deal with fractional flow reserve. We're going to look at a couple of clinical studies and then finish up with some things about FAME3 and where FFR is going in the foreseeable future here. So as was just mentioned, there's a lag between the European Class 1 recommendation for FFR guided PCI and the Class 2A recommendation that we currently have in the U.S. Guidelines. So Bill, can you comment on what you think it's going to take to up this to a Class 1?
Yeah, I think you're exactly right when you mentioned that there's a lag, and the published data, always precedes ultimately what comes out in the guidelines. And now that we have FAME2 as well as FAME1, so two multi-center international randomized studies, large groups of patients showing the benefit of FFR guidance, I think that it should and will get moved up with the next guidelines to a Class 1.
Good. And I know, SJ, you can sort of pick between the U.S. guidelines or the European guidelines. So what do you think here in Korea? What's the practical application here?
So we have our own guidelines in terms of we follow the ESS guideline further. And however, what I'm mentioning about is just the angiographic estimations would be Class 3B, right?
Yeah.
I think it's quite big changes, right?
Yeah. And one thing I hope they change is currently they have either FFR or IVUS for intermediate lesion assessment, and I certainly hope that they get rid of the IVUS part because I think we all agree that FFR is the better way to assess functional significance.
There's been so many studies now that have shown the inability of IVUS to predict functional significance. I think even the strongest IVUS advocates agree for epicardial lesions, FFR is the way to go.
So I'm just going to mention the FAME 2-year follow-up. You mentioned, Bill, you hope that this data may help sway the guideline writers towards. Do you want to just highlight now the 2-year information here? What's new? What's different? Is it the same, or did anything change?
I think one of the concerns about FAME 1 and the 1-year follow-up was that it was just 1-year follow-up, and there were about 500 significant appearing lesions based on the angiogram that were deferred because the FFR was not significant. And of course, there's a concern that those lesions are going to end up causing events later on down the road, and 1 year is probably not adequate. And so now 2-year follow-up supports that these lesions remain stable with medical therapy, and you continue to see the lower rates of death and MI in the FFR-guided group, as well as overall MACE. So I think it's reassuring to always have longer-term follow-up, and we hope to have the 5-year data coming down the road soon, and that'll be interesting to see what that shows.
So, Dr. Van Belle, in France, has FAME changed the FFR landscape the way it has certainly in the United States?
Yes, but indeed, FAME and also our own registry that we run in France help to implement the use of FFR. But we have also to keep in mind, and it's one of the points that we'll have to discuss, that basically there is also a gap between the studies that have been done mainly in patients already selected for PCI, that is basically then FFR is used as an adjunct to PCI, and the use in most centers in Europe at least to use it to, let's say, choose between the revascularization strategy, which is maybe medical treatment or bypass surgery. And it was not really covered by the FAME study. So there is still a gap there between basically the practice and the studies.
Okay. So let me show you this next slide, which I think is very sobering. There is an uptick, and this slide is only through 2009, but the data through 2012 shows that these all rise somewhat after the FAME was published in around 2009. And SJ, you've certainly had the most dramatic uptick in the use of FFR, and you've done a wonderful job of presenting that data. So for you, it's a moot point. You bought into FFR and you're using it fully. What do you think it's going to take for the average person doing PCI to believe in FFR and do FFR?
Right. We analyzed our kind of a retrospective registry data before routine use of FFR and after routine use of FFR. By define the routine use of FFR, actually per patients we used around more than 50%, 60% of patients we used FFR.
And I've got some of that data up here.
Right,
as well.
right, exactly. And so after routine use of FFR, anyway, we get clear as a primary endpoint. Death MR repeat revascularization is reduced. Relative reduction is almost 44%. And if you look at the FAME2 study, the composite endpoint mainly myocardial infarction frequency is a little bit different, right? Death MR difference, however, mainly. So based on our data, is almost the same findings. The frequency of peri-procedural myocardial infarction and repeat revascularization rate is clearly reduced. The reason why leading to the primary endpoint, composite endpoint reduced after routine use of FFR. And so after routine use of FFR, anyway, we can reduce the number of stents per patients, and we can reduce the procedure-related peri-myocardial infarction, and we can reduce repeat revascularization. Then maybe the message from our data.
So your data shows clearly that using FFR routinely, and which is roughly 50%, because a lot of the lesions don't need FFR, but in any lesions that have any question about them, you use FFR, reduces death and MI. That's pretty good data. Why aren't people using it? Why are they not convinced by reducing death and MI in their patients?
Maybe one of the question behind it that is not really talked about is that most of the interventionalists are afraid of using FFR because they believe, based on the DFAIR study, that they will lose 50% of their PCI. And it's not really told, but it's in the mind of most of the interventionalists. And again, if you come back to our own French registry, we demonstrated that if you use FFR upfront at the diagnostic phase, you can demonstrate that you will reclassify patient also from medical treatment to PCI or from surgery to PCI. And in our own registry, the number of patients referred to revascularization only decreased from 45% of the overall population to 43%. So only a minor decrease, which was different from the DFAIR study, where all the patients enter the study because they were supposed to get a PCI.
Right.
So
and this is the R3F trial?
That's true.
And where was that published?
In Circulation recently.
Great. Okay.
So this is, I think, an important piece of information to show that indeed you will not lose so many revascularization if you use it largely.
Right, and I know there have been several studies that have shown that you can basically convert bypass surgery patients into cath lab patients who get PCI. And while we're talking about bypass, I've got up a slide about the FAME3, which is people with angiographic 3-vessel coronary disease who are then going to meet with a heart team, which I think takes away some of the concern that you're pre-selecting, special patients. So Bill, can you describe the thought behind this trial and how you see it adding to the evidence we have now?
Sure. Well, the background behind FAME3 is that, of course, the SYNTAX study showed that in patients with multivessel disease, CABG performed better than PCI. But there were two issues with SYNTAX in particular. I think one was that it was using first-generation drug-eluting stents, and we're all aware of the issues with those. We now have second-generation drug-eluting stents, which have been shown to have lower rates of death and MI when compared directly with first-generation. So one could hypothesize that you might get a different result with better stent technology. The other issue is, of course, FFR guidance wasn't used in SYNTAX, and we saw in FAME1 in patients with multivessel disease that there are lower rates of death and MI with FFR guidance compared to angio guidance, which was done in SYNTAX. So with that background, the hypothesis is that in FAME3, The combination of FFR-guided PCI with second-generation drug-eluting stents will be non-inferior to CABG in patients who have 3-vessel disease not involving the left main. And enrollment should be starting in the next, hopefully, 6 to 8 weeks. And there'll be 1-year follow-up as a primary endpoint and 3-year follow-up as well.
So what are you projecting for an endpoint of MACE?
We expect the CABG arm shouldn't be much different than what was seen in Syntax. And so looking at death, MI, stroke, and repeat revascularization, it was about 12%. And so that's what we're projecting will occur in FAME3. And the hypothesis is that the FFR-guided PCI arm will have a rate somewhere in that range as well.
Okay, and it's a non-inferiority
Non-inferiority,
design.
yeah.
Okay. So, SJ, are you excited about this trial? Do you think it's going to add to what we're looking for with FFR? You're such a big proponent of FAME3.
FAME3 study, right? Right. There is. I think it will be a kind of a milestone to change our practice concern.
Mm-hmm.
So you just mentioned about why do we not too much concern about the FFR practice. It's, actually we don't have confidence during the last almost 30 years, 40 years. We are very much familiar with angio-guided procedures. So we have to change this, and we need more solid data, just like a FAME3 study. And so quite a different concept with the Syntax studies, right? Basically use the first generation, so Belle mentioned about that. And another issue is they actually very much attached to the complete revascularization concept with including the small vessels and no concept of FFR guidance, etc., etc. And so finally, FAME3 studies will give us a more solid answer in the future.
So in light of the complete revascularization concept, what are you anticipating will be the difference in the number of lesions or vessels treated in the two arms?
Yeah, so we expect that the surgical arm will get, on average, probably 3 bypasses. But in the FFR-guided arm, we saw that of the 3-vessel disease in FAME1, the vast majority only had 1 or 2 vessel functional disease, and only about 15% had actual functional 3-vessel disease. So we would expect a similar pattern in FAME3.
Yeah, and you'll probably have some who get nothing.
Probably there'll be a few, yeah.
Yeah, okay. Well, good. So this is just now we're at the quote discussion slide. We have a few minutes left here. We've talked a little bit about the really excellent work that's out there now about FFR, about the fact that some of us have become believers, what we might expect from the FAME3 trial. So Dr. Van Belle, in Europe, cost is usually a major barrier. What is your feeling about FFR, your use in Europe, and what's the future there?
Yeah, there is discrepancy among Europe regarding the use of FFR. It's a relatively large use in the north of Europe, mainly related to some reimbursement, and a lower use in the south of Europe, again, because of this. What we expect is because of this, the accumulation of the data that we have, that the reimbursement will be much better, and then the use of it will be increased. And probably also one of the issues that we have to discuss, and one of the limitations that we have, is now we refer to the use of FFR relative to the number of PCI, but I'm not so sure that there's a real way of counting it. Probably in the future we'll have to count relative to the number of angio we do. The question is whether FFR is an adjunct to PCI, or is it should the FFR being used at the stage of angiography to choose the best treatment, which is probably the next next step to go.
And I would say that's the way we've been using it.
Yeah.
We have far more FFR in diagnostic angiograms than we do in PCI. Basically, just to show everyone that we don't need to treat this particular patient, and no one's going to come back later and say, what about that lesion? So let's spend just a minute on this new hyperemic stimuli, the A2A agonists. Are any of you using those? So what do you think about those?
No, I don't have any experience with it.
Okay.
Yeah, we still stick mostly with adenosine, either intracoronary or intravenous. Regadenoson has some attractive aspects to it in that you can give a bolus peripherally and have a more prolonged hyperemic effect. And there are new data supporting its use and showing that it's equally efficacious as far as hyperemia when compared directly to IV adenosine. It is more expensive, but may be associated with less side effects as well. So I think it's a move forward, and anything that simplifies the approach I think is welcomed. But I think good old adenosine works pretty well too.
SJ, how about here in Korea? Any use of regadenoson?
No, so we routinely use IV adenosine.
Yeah.
For the
I think the symptoms are clearly less than IV adenosine, but if you use intracoronary adenosine, they don't have any symptoms anyway. So personally, I still think intracoronary adenosine is the easiest for the vast majority of patients. So we got a minute or so left. A couple of seconds from each of you about 5 years from now. What will be the state of functional evaluation? SJ?
5 years, it'll take a little bit more time. So, however, anyway, the FFR guided procedure is getting increased, 25 and 30% in our practice. That may be successful, right?
Okay. Bill?
I think our non-invasive evaluation of functional significance with things like FFR CT will have improved, and the upstream evaluation will be much better. In the cath lab, I think the approach will be further simplified. Wires will get better, techniques will get better, the integration to the cath lab system will be more streamlined so that there'll be really no reason not to use it. And the data, there'll be continuing to be more and more data supporting its use.
Yeah, and for me, just to follow the previous part of my of the discussion, is that for sure physiology will be part of the diagnostic phase. Clearly, either non-invasive or in combination with the angiography, and as an adjunctive tool to PCI. The next, maybe next issue with that we don't know really what will the future on will be the instantaneous free ratio evaluation. That is kind of FFR without adenosine. We are not really sure what will be the future, but maybe there is some place for this technology there.
Yeah, I think for me, I continue to be frustrated by these non-invasive stress test results that are uninterpretable and often wrong. And there's many days when I wish we just take a patient with chest pain, take them to the cath lab, do the angiogram, do the FFR, and get the right answer. And maybe the FFR CT is a better way to screen them. Unfortunately, in the United States, it is almost impossible to get a CT because no one will pay for it, which is unfortunate. But I think I would agree with all of you that there will be a continuous move towards functional evaluation, which of course has its roots in stress testing for years and years. So thank you very much for your opinions, and enjoy the rest of TCTAP.
Thank you very much.
Thank you.